Hello everyone. Today we'll discuss about the dyslipidemia in diabetes. Dyslipidemia is one of the macrovascular complication in a patient with diabetes. In the patients with diabetes, the increased prevalence of dyslipidemia has been noted, and this dyslipidemia is abnormal metabolism of the lipids in the body, which ultimately causes the generation of the cardiovascular complications. This abnormal lipid metabolism is due to impaired insulin secretion or due to insulin resistance in a patient with diabetes. The characteristic feature of this dyslipidemia in diabetes are high triglyceride levels, increased low density lipoproteins, and low level of HDL cholesterol in the body. Among the diabetic patients, it is seen that patients with poor glycemic control have increased risk of having dyslipidemia as compared to the patient with good glycemic control. Same has been proved by the two of the studies. The first study was conducted by Cathala C et al. And as per this study, about 97.2% of the patient with diabetes, they have abnormal level of lipids, which indicates the dyslipidemia. Another study by Hatanda S, it says that the prevalence of dyslipidemia as well as the lower level of HDL, which is a good cholesterol, is almost 95% among the diabetic patients, which shows that the major derangement in respect of lipids are seen in the patient with diabetes. Development of dyslipidemia in type 2 diabetes mellitus is associated with the metabolic syndrome, as we know that the metabolic syndromes are the consequences or the conditions which are developed due to the clustering of the various risk factors, and this metabolic syndrome includes stroke, hypertension, some cardiovascular diseases, as well as the diabetes mellitus. And these metabolic syndromes or dyslipidemia are due to the insulin resistance, as we have already studied, or due to the insulin insensitivity, which is accompanied by the adipocytokines. In dyslipidemia in patient with diabetes, two kind of changes have been seen: the quantitative changes and qualitative changes. In quantitative changes, there is abnormal or increased level of low density lipoprotein will be seen. In qualitative changes, we will notice the increase in level of atherogenic small dense low density lipoprotein and oxidatively modified low density lipoprotein, and these two kind of low density lipoproteins are dangerous or are bad kind of cholesterol. Now let's discuss the pathogenesis of dyslipidemia in patient with diabetes. So in a patient with diabetes mellitus, we will see the hyperglycemia, increase in blood sugar level, as well as insulin resistance. This condition will lead to destruction of the fats into free fatty acids and glycerol, and also there will be decrease in lipoprotein lipase activity. All these conditions will cause dyslipidemia, which we have already discussed, in form of hypertriglyceridemia, the low level of HDL cholesterol, which is a good cholesterol, increase in level of small dense LDL cholesterol, which is a bad cholesterol, as well as the increased level of apolipoprotein B, which is also a bad cholesterol. This all will lead to add-on chronic kidney disease. This chronic kidney disease is common in the patient with diabetes mellitus, and it is because of oxidative stress, advanced glycation end products accumulation, as well as the interruption or abnormality in renin, angiotensin, aldosterone system in kidney, and ultimately all this will lead to chronic kidney disease. In diabetes mellitus, few other abnormalities like obesity, hypertension, oxidative stress, decreased nitric oxide, and chronic inflammation. Apart from that, the atherosclerosis all will lead to development of the cardiovascular diseases in a patient with diabetes, which will result as either coronary heart disease or cerebrovascular disease or peripheral arterial disease. This cardiovascular condition will also add on the in the condition of chronic kidney diseases in form of hypertension, chronic inflammation, and endothelial dysfunction. So these are the whole pathogenesis of dyslipidemia in a patient with diabetes. So now let's discuss the importance of non-HDL cholesterol. As we know that HDL cholesterol is an example of good cholesterol, and non-HDL cholesterol are groups of atherogenic lipoproteins. So this non-HDL cholesterol measurement provides a single index of all the atherogenic apolipoprotein B containing lipoproteins. This include low density lipoprotein, VLDL, very low density lipoprotein, intermediate density lipoprotein, and lipoprotein A. All these are non-HDL cholesterol, and so this measurement of this non-HDL cholesterol in a patient with diabetes is more practical, reliable, and inexpensive way to detect the condition of dyslipidemia. It is seen that measurement of non-HDL cholesterol in non-fasting state is more reliable, more relevant as compared to the measurement of LDL cholesterol in presence of postprandial hypertriglyceridemia, in which the LDL cholesterol are measured incorrectly. Whenever a patient with diabetes comes to the OPD, so firstly we have to perform the atherosclerotic cardiovascular disease risk assessment of that person, and this risk assessment is based on 5 major atherosclerotic cardiovascular diseases risk factors, as well as there are 7 other high risk features as per this table. Apart from that, there are 4 moderate risk non-conventional risk factors. So based on these 3 categories of the risk factors, the patient is classified into various categories: very high risk for the atherosclerotic cardiovascular disease, high risk, the moderate risk, and the low risk. And according to his risk factor risk assessment, the patient gets treatment for the dyslipidemia. In this slide, we can see how the 2 classified groups of very high risk and extreme risk groups are treated according to their LDL cholesterol goals. This slide shows the cholesterol goal, the level of cholesterol which is to be maintained, and the threshold for which the statin therapies are initiated according to their categories. Now let's discuss the management of dyslipidemia in a patient with diabetes. So as we have already studied that any patient with diabetes has increased risk of development of cardiovascular complications. So to improve the quality of life of the patients based on their characteristics and requirements, the treatment should be individualized, and among them the lifestyle modification plays a very vital, very important role in the management of diabetes. This therapeutic lifestyle change, lifestyle modification includes the reduction in the weight loss, and dietary modifications. The weight loss has been found the reduction in the triglyceride level, as well as it increases the level of HDL cholesterol, which is a good cholesterol. However, the effect on LDL cholesterol level is modest in case of therapeutic lifestyle changes. Now let's discuss to the dietary recommendations. The dietary recommendations in a patient with diabetes who has high risk of development of dyslipidemia has reduction in the calorie intake. The patient should also limit the intake of saturated fats. It should be less than 7% of the total fat. The cholesterol consumption should be less than 200 mg per day. Trans fats should be minimal, ideally less than 1% of the total fat, and the patient should increase the intake of dietary fiber. Apart from that, the patient also needs to limit the intake of sodium, which should be less than 2300 mg per day. Also, the alcohol consumption should be reduced, like in men it should be less than 2 servings per day, and in case of women should be less than 1 servings per day. Another very important factor in management of dyslipidemia is physical activity, and the person or patient should perform the moderate physical activity or exercise. Apart from that, the person can also perform the other form of physical activity, which includes the yoga, jogging, gym, etc. Now let's discuss the pharmacological therapy of the dyslipidemia. The pharmacological therapy or drug therapy is an important form of management of dyslipidemia in patients with diabetes, apart from therapeutic lifestyle changes. And the indication to start the drug therapy is when the therapeutic lifestyle changes fails to achieve the target level of cholesterol after 3 months of duration. So, in a form of drug therapy, we have many options. The statins, which are HMG coenzyme A reductase inhibitors, are the drug of choice for dyslipidemia in a patient with diabetes. Apart from the statins, we have some other agents which are very effective, like FIBRATES, niacin, ezetimibe, and PCSK9 inhibitors, which can also be useful in some selected situation. As we know that the diabetic patients are at high risk of developing the lipid abnormalities, which can contribute to development of atherosclerotic cardiovascular diseases, and for that we should manage such kind of patient of dyslipidemia in diabetes with lipid lowering agents or drugs. For that we should follow the ADA, American Diabetic Association, recommendations to treat any patient with lipid abnormality. And this American Diabetes Association recommendation includes that if any patient is not on statin therapy, so in that condition the lipid profiling should be done at the time of initial diagnosis and thereafter in every 5 years. If statin has already been prescribed, then the lipid profiling should be done before initiating the therapy and thereafter frequently whenever the physician feels. If the triglyceride level are more than 500 mg per deciliter, then in that condition we need to evaluate the secondary causes of this hypertriglyceridemia, because this hypertriglyceridemia has increased risk of development of pancreatitis. So in that condition we need to start medication immediately to reduce the risk. And here are some medications which have been recommended for the patient with dyslipidemia. These are statins, FIBRATES, ezetimibe, the purified omega-3 fatty acids, the bile acid sequestrants, the PCSK9 inhibitors. Now let's discuss about the statins. So statin therapy has been found to significantly reduce the LDL cholesterol level. However, this has modest effect on HDL as well as on triglycerides, and these statins reduce LDL cholesterol by 30 to 50%. However, these statins are contraindicated during the pregnancy. The main mechanism of these statins are that they inhibit one of the enzyme which is known as HMG coenzyme A reductase, which is a key enzyme in biosynthetic pathway of cholesterol. We can see here how these statins effect are on this enzyme and how this block the formation of cholesterol. The statin therapy can be given in two forms: the high intensity statin therapy and the moderate intensity statin therapy. The high intensity statin therapy lowers the LDL cholesterol by 50%, and in this high intensity statin therapy, the dose includes the atorvastatin 40 to 80 mg OD, rosuvastatin 20 to 40 mg OD, and in moderate intensity statin therapy, it reduces LDL cholesterol by 30 to 50%. And here are the drug doses in moderate intensity therapy. However, the statins have some adverse effects, as it can cause myopathy, which can range from non-specific myalgia to frank rhabdomyolysis. It has some GI side effects in form of nausea and flatulence. Some CNS side effects are there in form of insomnia and nightmares. As we have already discussed that statins are contraindicated during pregnancy. Here in this slide we can see the treatment algorithm for the cases of hypertriglyceridemia. There are various different treatment protocols for the different level of triglycerides. The another class of drugs are fibrates. These fibrates are actually the peroxisome proliferator activated receptor alpha agonist. We can say these are PPA or alpha agonist, and this class of drugs activate this receptor, the PPAR alpha receptor, in liver, muscles and adipose tissues. This ultimately causes the activation of lipoprotein lipase, increase in fatty acid oxidation, increase in HDL cholesterol, which is a good cholesterol. Also, it increases the clearance of the remnant lipoproteins from the body, and the net effect of these fibrates by this four mechanism is reduction in the triglyceride, increase in the level of HDL cholesterol, and the reduction in the LDL cholesterol. The same mechanism of action is shown in this diagram, as the fibrates can activate the PPAR alpha receptors in liver, adipose tissue, and ultimately this will lead to reduction in the bad cholesterol and increase in the good cholesterol, HDL cholesterol. The examples of fibrates are fenofibrate, gemfibrozil, and bezafibrate. As the statin has side effects, the fibrates are also having some kind of side effect like myopathy, hepatotoxicity, raised in serum creatinine level. The fibrates have been shown reduction in the microvascular complication in field trials. However, in large clinical trials, such kind of reduction in microvascular complications has not been noted. There are no improvement in cardiovascular endpoints. The another important class of drugs are ezetimibe. So these drugs have effect on one of the protein which is known as thiamine PIK-C1 like 1 protein, and they lower the cholesterol level by the blocking of this protein, and this protein is the critical mediator in the absorption of cholesterol in GI epithelium cells as well as the hepatocytes. So the ultimate important mechanism of these drugs are reduction in the absorption of the cholesterol by blocking the one of the protein, that is NPC1L1 protein. So this class of drugs of ezetimibe can be an alternative to statin therapy. In patients in which the statin are less effective, less potent, and intolerant to statins. However, the potency of these drugs compared to statins in lowering the LDL cholesterol are less. Here in this diagram, we can see how this ezetimibe blocks the NPC1L1 protein, which is a important mediator in absorption of dietary and biliary cholesterol into the GI epithelial cells as well as the hepatocytes. This class of drugs, ezetimibe, can be used in combination with the statins, as this has some additional lowering of lipid levels lower when they are given with statins. This combination can also reduce the risk of adverse cardiovascular events, which is more in case when the statins are used alone. However, this class of drugs are well tolerated by the patient, but few patients can show the symptoms in the form of the headache as well as in malabsorption, steatorrhea. The another class of drugs are purified omega-3 fatty acids. These drugs are usually used to lower the triglyceride levels. However, they are not potent on acting on HDL as well as on LDL levels, cholesterol levels. By acting on the lipids, vessels and platelets, these omega-3 fatty acids has cardiovascular protective mechanism. The another class of drugs are bile acid sequestrants, and this class of drugs are used to reduce the level of LDL cholesterol. This class of drugs are also effective on improvement of the blood glucose level in a patient with diabetes. The example of bile acid sequestrants are colesevelam, and in this diagram we can see how this bile acid sequestrants works on lowering of this LDL cholesterol. The next class of drugs are PCSK9 inhibitors. Actually, these are monoclonal antibodies. They bind and inactivate one of the hepatic protease known as proprotein convertase subtilisin caxin type 9. This protease, usually in normal mechanism, attaches with LDL receptor and internalize this LDL receptor into the lysosome, and in lysosome this LDL receptor get destroyed. When these monoclonal antibodies known as PCSK9 inhibitors are used, they will inhibit this hepatic protease PCSK9, and it will increase the number of LDL receptor which will available on the surface of hepatocytes, and by this they will increase the uptake of LDL proteins, low density lipoproteins from the circulation, and ultimately they will lower the concentration of LDL from the circulation. These medications are effectively and they reduce the LDL levels by 36 to 59%. Here we can see the mechanism of action of this PCSK9 inhibitors. In normal mechanism, this PCSK9 hepatic protease will increase the availability of LDL receptor on the surface of hepatocytes, and then they will increase the level of LDL into the circulation. In presence of this PCSK9 inhibitors, this LDL receptor will not be available for the surface of hepatocytes, and this LDL receptor will be taken into the lysosomes for the destruction, and ultimately the level of LDL will decrease. These PCSK9 inhibitors are used in those patients who are unable to maintain the level of LDL up to the target level in spite of use of high intensity statin therapy. These drugs are approved as adjunctive therapy for those patients who are with atherosclerotic cardiovascular disease risk or who are having familial hypercholesterolemia. However, they are receiving the maximum tolerated dose of statin but still there is some requirement to lower the LDL cholesterol more. The addition of these PCSK9 inhibitors have been shown to reduce the adverse cardiovascular outcome significantly in such kind of patients in whom we have already used the maximum tolerated dose of statin, but still they are unable to get their target level of LDL. Few examples of these PCSK9 inhibitors are evolocumab and lirocumab. The another class of drugs are SAROGLITAZAR. These are novel lipid and glucose lowering agents which have been developed in India. This class of drugs act as a dual. They act on PPAR alpha as well as PPAR gamma agonist. However, the action as PPAR alpha agonist is more dominant as compared to the action as PPAR alpha agonist, gamma agonist. They decrease the plasma triglyceride levels as well as they increase the HDL cholesterol levels also, which is a good cholesterol, and this increase in HDL cholesterol level is by increasing the hepatic production of its components like apolipoprotein A1 and A2. SAROGLITAZAR also reduce the HbA1c modestly, and this is by its action on the PPAR gamma receptor. So this SAROGLITAZAR is indicated for the treatment of diabetic dyslipidemia and hypertriglyceridemia who is having diabetes mellitus type 2, and these patients are not controlled by the statin therapy. The usual dose of this SAROGLITAZAR are 4 mg once daily. In these slides, we can see the mechanism of action of this SAROGLITAZAR, as we have already discussed that they act as an PPAR alpha agonist as well as PPAR gamma agonist, and by this PPAR gamma agonist it increases the insulin sensitivity, it increases the glucose uptake, fatty acid uptake and adiponectin. So it has important action on lowering the blood glucose level, and ultimately it reduces the cardiovascular disease events. The combination therapy of statin and PCSK9 inhibitors are usually recommended as an adjunctive therapy in a patient of diabetes with high risk of atherosclerotic cardiovascular diseases. However, the combination of statin and niacin is usually not recommended, as this combination can increase the risk for ischemic stroke as well as there are some other complications with this combination. The ABCD strategy in patient of dyslipidemia in diabetes: we must advise the patient and his family in respect of the preventive measures for the dyslipidemia. The blood pressure control is very important in a patient with dyslipidemia. Apart from that, the cholesterol levels should be checked regularly as well as the level of cholesterol should be maintained properly either by the dietary modification, lifestyle modification as well as by the drug therapy, and we should detect early the abnormal lipid and cholesterol levels so that we can prevent the complication of such abnormality. Thanks for watching this video. Please like and share with others.